Sir, we are live now. With all your permission, I'm starting this webinar for today.
Sure.
Good afternoon to everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Sujit Ash, sir. And let me share some of the achievement of sir. Sir has done MBBS, Diplomate of National Board in Obstetrics and Gynecology, and Fellowship in Minimum Access Surgery, World Association of Laparoscopic Surgeons, WALS, Diploma in Gynecological Endoscopy, Kai University, Germany, IRCAD from France, Senior Consultant in Gynecology, Obstetric and Gynecology Department at PD Hinduja Hospital, Mumbai. And today, sir is going to discuss on a topic decoding basics hysteroscopy. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed.
Right. Talking about hysteroscopy and the basic things that you all need to know. It's a little big lecture. I'll try to scoop up all the points, whatever is important. So that's the topic for today, decoding basic hysteroscopy. So where all do we need hysteroscope? So when I'm sitting in the OPD or you're sitting in the OPD, you might have certain patients who might come with either complaining of menorrhagia or intermenstrual bleeding or intermittent spotting or random bleeding throughout the menses, or who is trying to conceive. That might be a menstrual or a perimenopausal woman. Once the woman is menopausal, you might have a complaint of postmenopausal bleeding or an ultrasound finding which is suggestive of an endometrial thickness of more than 4 millimeters. Or again, there might be breakthrough bleeding when the patient is on HRT. So all these things might be a scenario that you or I will have definitely come across during our practice. So what do? We assess this patient thinking about the history of the patient, a proper examination, whether it's a per vaginal, per abdominal, per speculum examination, or you can do a smear test, which is something which I make it mandatory to rule out cervical cancers. Olden days, we used to do a PIPEL or a just part in a small catheter and do in an endometrial biopsy. But nowadays, the better thing is just ask for a sonography, where we ask for a transvaginal route to find out any abnormality which is related to the uterus or the ovaries. And then I plan for hysteroscopy, which can be the diagnostic or therapeutic. Why? Because my aims are to give the woman a betterment of life so that the abdominal vaginal bleeding, what she's suffering from, is stopped. Hysteroscopy is something which I can do diagnostic and therapeutic at the same time. And it's easy. Once the scanning is done, I know what I'm targeting at, and then I do the procedure, and it's very quick. So it's not something which will require a uh, long surgery duration or something. So since it's quick, it requires maybe very minimal anesthesia, and therefore it can be done on a daycare basis also. And therefore it improves your patient load and it improves the patient outcome. So what do you require while doing a hysteroscopy? You require a camera so that you can relay whatever you're doing. You'll require a light source so that you can see whatever is there inside the cavity. And you'll require a recording system so that you can record whatever is happening and you can hand it over to the patient or keep it for your database. So this is the basic thing. But the major thing is the scope. You have to see what is inside. So you can do it with two types of scopes. One is better T scope, which is the in thing nowadays, because it's a very small scope. It's only 2.9 millimeters and it has very excellent optics. So this is one company which is manufacturing the better T scope. And with adding to the sheet or the covering around the hysteroscope, it comes to a diameter of only around 3.7 millimeters. And the distension media can be either normal saline, so as the pressure that you have to maintain is 75 millimeters of mercury. So this is the basic Bertocci system whenever you require it. The thing was actually started by Stefano Bertocci in 1997. Vaginoscopy, first doing a vaginoscopy and then introducing a Bertocci's hysteroscope. And with that, he's done around 1200 hysteroscopies since I last prepared this slide. So this might be at least 5-6 years back I did this slide preparation. So at that time he had done 12,000. Now it is more than that. But in a regular setting, what we nowadays still do is a basic hysteroscope where we have a 4 millimeters hysteroscope. Along with that, we add a sheet to it, so the diameter comes to around 6 millimeters. If I need any operating element along with it, then I put an operative sheet, so that's 8 millimeters. And if I think that I have to do a resection because of any septum or because of any fibroid, then I add in a resectoscope, so that's 10 millimeters. So that is how you remember 4, 6, 8, 10. And the different things that can go in the operative sheet are scissors, biopsy forceps, graspers, or polypectomy loop, or myomar fixation screw. These are the few things that you can see once you go inside. So the first thing that you see is I'm seeing the cervix as I'm going inside, either with the vaginoscope or directly when you go in. Then you see the cavity. As you just go inside negotiate the cervix and go inside, you'll see the cavity. And when you see the cavity, you will see a panoramic view and you check for the two ostia. So the cavity can be first, second, or third. In the fourth picture that you see down is a small fibroid-like structure which is seen. Fifth one is a polyp. Sixth also is a polyp. Now these are the pathologies you might be coming across. So how we tackle? So if I have to operate, I have to think about any medication that I need to give. And I'm the anesthesia. So the anesthesia I usually prefer is a short-acting general anesthesia. My procedure hardly takes around 5 to 10 minutes. So I just tell my anesthetist that I need some kind of a short GA, either with an LMA or whichever way she can manage or he can manage. So 10 minutes and my procedure is done in and out. So what are the operative procedures that we'll be doing? We either do endometrial biopsy, we do a polypectomy, lost IUDs can be retrieved. If there are any synic here or additions which are found, we separate that. Myomectomy can be done, and hysteroscopic sterilization is also possible. So again, in this picture, if you see, there is a small polyp at the posterior wall, which is removed with a scissor. And in this, you can clearly see the polyp on the right corner, which is being cut by the scissor. So this is polyp. So what are polyps? Polyps are hypoplastic growth in the endometrial gland and stroma. So we have to treat any polyp because this can interfere with a lot of other things. There are different etiologies which can be there. Most of the times it can be because of unexposed estrogen, unexposed estrogen to the endometrium. That is why the polyps are seen. This is majorly also seen in cases of IVF treatment. So what can this lead to? This can lead to irregular menstrual periods, unusual heavy flow during menstrual periods, or bleeding or spotting between periods, vaginal spotting or bleeding after menopause, and infertility. Yes, polyps can cause infertility because they affect the embryo implantation, and therefore defective embryo implantation of the polyp can defective embryo implantation of the embryo can lead to high incidences of miscarriages. Also, this polyp can induce local and inflammatory changes that also will interfere with the implantation. Plus, these polyps secrete something which is known as the glycodyl. Glycodyl is a glycoprotein which also acts as an inhibit natural killer cell activity, which again renders the endometrium less receptive to implantation. So all these things can lead to infertility. Therefore, you need to remove the polyp. So how will you diagnose the polyp? Firstly, it's either TVS or saline infused sonography or HSG or hysteroscopy. TVS can form the mainstay of treatment. Always ask for a polyp checking around the 10th or 14th day, between the 10 to 14 day of the period, so that you can find out the polyp properly. Later half, if you do it, then what happens is your lining itself will start becoming thicker, and the initial half, the patient is bleeding. So always better would be between 10 to 14 days of the cycle. In this picture, you can nicely see a small polyp in the endometrial cavity. Saline infused sonography can also be done when you pass in the saline and check for the movement, and that can also show me the polyp in the uterine cavity. You can also do an HSG. HSG will also delineate the polyp. This was something which was preferred in the ancient days. Now, obviously, we prefer the sonography which is there. Hysteroscopy itself can sometimes help be the diagnosis of the polyp, and you can use it for treatment. You can wait on the polyp and think about whether the polyp can regress spontaneously. If the polyp size is less than 10 millimeters, then it can regress in 25% of cases. But most of the time, the polyp is persistent, so you'll require surgery because medical management has a very limited role and most of it doesn't work. So in surgery, you will do a hysteroscopic polypectomy. So basically, you prepare your hysteroscope along with an operative sheet and you use a 5 French hysteroscopic scissor. And you can go inside, check on these are the instrumentation which are there. Check on the polyp, and then you can just slice off the polyp whenever it's required. So whenever you're doing a hysteroscopy, so these are the basic steps where you start it. You check for the sim speculum or the valcellum, and you hold the cervix. Then either use a Hagas dilator to dilate, or if the cervix is dilated, directly pass in the hysteroscope along with the setup of the light source and the operative sheet. If resectoscope is required, then use a resectoscope. Your distending media can depend on whichever energy source you're using. If you're just using simple scissors, then you can ask for a normal saline. Camera will be recording everything, and accordingly, whatever you require, you can use your instruments. And depending upon if you have the polyp, which is a large one, you can remove it with ovum forceps. If it's a thickened endometrial cavity, thickened endometrial lining, then you can use a suction curette and remove the thickened lining, or you can use a sharp curette, whichever you're comfortable with. Whenever you're doing this, remember that major issue that can happen with any hysteroscopy thing is your perforation and your fluid overload. So you need to remember that don't go overzealous into doing any cutting or any dilatation. And whenever you're doing the procedure, try to finish it as fast as possible so that you don't land up with any fluid overload. So under general anesthesia, the surgery is preferred to be done during the proliferative phase because you have a better endoscopic view and there's no chance of pregnancy also. Multi-channel operative hysteroscope is used, and if you require, you can use either a scissor or you can use a current and nip it off with your forceps, and the current should be around 30 to 40 watt. And when you remove, examine the site to rule out any bleeding and make sure that you have removed, if there's a pedunculated polyp, removed from the stem and not from the stem is removed from the base and not in between, so that there are no chances of having a recurrence. So, like I said, the polyp is cut from the base and separated. Polyp can be removed with ovum forceps or polyp removal forceps, and do a check hysteroscopy to check for any bleeding or just to rule out if there's no other pathology which you are leaving behind. So this is how a operating hysteroscopy sheet would look. So you have the scope which is there, which is connected to the sheet with the inflow and the outflow channel. And the one where the operating instrument enters in, that's the operating channel, where you see the scissors. In the front, you see how the scissors open. This is a big magnification which you see under the lens, but otherwise it's a 5 French scissor which is very small. So this is how we do a operative hysteroscopy along with scissors. You can also use a resectoscope with loop electrode, which can be used in cases of fibroids also, which we'll be discussing later on in the next few slides. Complications that you can come across while doing the surgeries are you might have an uterine perforation, or there might be bleeding or thermal injury. Fluid overload, which is something which is very important. If you have a fluid overload, you might have electrolyte imbalance. That can lead to symptomatic hyponatremia. The patient might land up with confusion or cardiac issues. So the advice would be always do a electrolyte level before the surgery. In a situation where you are expecting that there might be fluid overload, and you'll do a proper charting of the fluid. How to manage your fluid, I'll be discussing in the towards the end, that I have a small presentation on that. You need to plan termination of the procedure early if you're thinking that there might be fluid overload or there are some complications which has happened in. And if you're doing overzealous curating, you might land up with infertility because of adhesions which are there. And if you have a perforation or if it's not successful, then the procedure might require a laparoscopy or convert it to a laparoscopy. The other thing that we can come across while doing hysteroscopy is uterine anomalies. These are the types of anomalies. I guess everyone out there usually knows about these anomalies. So you know that as per the evolution what we have and the development from the embryo, we have paranephronephric duct which have to fuse and then unfuse and form a cavity, and that can lead to septum formation. So these can lead to a lot of other issues, which can be miscarriages, preterm labor, or poor placentation. So you might have incomplete or partial septum, complete septum, or an arcuate uterus. So this is what you see. So it is always wiser to either do a 3D scan or do a concurrent laparoscopy whenever you're trying to do any septal resections. Because when you see the first picture and you see the second picture and the third picture is biconvex and the second picture is septate. If I don't have a proper scan or if I just go in directly with a hysteroscope and think that it's a septum, and if I start cutting for the second one, then obviously I'll reach up to a boundary where I'll have tissue. But if I start with the third one thinking that it's a septum, I'll perforate the uterus because there is no muscle in between and I'll just exit from the uterine cavity. So therefore, if you have a 3D picture, 3D ultrasound, or if you have a concurrent laparoscopy, you will be at a better position to differentiate between a septate uterus and a biconvex uterus. So you can diagnose either by HSG, but again, the wiser option would be a 3D ultrasound, and you can have a combined MRI pelvis also, or direct visualization with hysteroscopy and a laparoscopy. So if you see in this picture, that's a normal uterine cavity. And in this, you see a septate uterus. Why septate? Because if you look in the cavity properly, I've shown it with a black and white picture around. The M is the muscle. Okay. So M is the muscle, the CCC is the cavity, and the S is the septum. In case it's a biconvex uterus, the top M won't be there. So as soon as you start cutting the S, you'll perforate and reach out to the pelvic cavity. So that is why you have to be careful in such situations. This is in cases of HSG. Again, in HSG, I can't make out the muscle layer properly. Therefore, I prefer a 3D ultrasound. And this is MRI. Yes, MRI is also wonderful. If you have the facility, then ask for an MRI. Septum does affect and lead to infertility also because your placentation is affected. The placenta won't get enough blood supply and even the cavity is smaller. So therefore, the chance of miscarriages is more. So this is how a uterine septum usually looks under a hysteroscopy. So when you think about removing a septum, you can either do it by scissors or you can do it by energy source. Remember, whenever you're doing an energy source shift, you have to change your fluid media from normal saline to glycine if you're using a monopolar current. Otherwise, you'll have issues because of ionic movement. So in this, with the resectoscope, I'm just snipping off the septum. You can see from the first to second, the septum has separated significantly. Yes, usually after the pre-operative preparation is not that significant, but it's important to manage the patient post-operatively. You can use a vaginal misoprostol as you're starting to operate. Depending upon whichever source, either scissor or electrosurgery, you can prefer your line of treatment. And once you have done with this, you can just go inside and again relook depending upon how much distension you have achieved and how much benefit your resectoscope has done or your resection has done for the cavity. In this, you have to remember that antibiotics have to be continued. Hormone therapy can be given depending upon what you prefer. I usually prefer a 2 milligram estradiol valerate and a 0.5 milligram norestradol daily. This is usually what I prefer. Some usually also do. If I have a very large cavity, very large septum that I have dissected, I usually prefer also putting a pediatric Foley's inside the cavity for a week or two so that it doesn't collapse the cavity and it reduces the chances of adhesions. You can even put in an intrauterine device that also reduces the risk of adhesions. So the main idea is basically that I don't want any adhesions after the surgery so that the septum can reform again. So whichever way, so either you can prefer a 2 milligram estradiol valerate, or you can put in a pediatric Foley's, or you can put in an IUC. Complications, again, perforation, which can happen. You have to be very careful depending upon what you're managing. Bleeding can happen, and the patient has to be counseled that during pregnancy, you have to be particular so that you're not letting the pregnancy just continue for a long time, or the patient's complaints are not neglected. So you usually ask for a time interval of around 2 months post-surgery so that she can plan for conception. And outcomes are definitely better after you're doing a septal resection, which are stated by all these studies. I'm just taking it fast because I have around 150 slides for today. So you have to remember that imaging or study with hysteroscope along with a laparoscopy is always the best approach. Though it's a slightly more invasive, this is least invasive if you have to think about doing a laparotomy because of any complication that can occur later on. The other thing is tubal block. You can come across tubal blocks also at times. The percentage can vary. In infertility, it can be around 25 to 35%. The major thing that you need to know is that tubal block can be cause of multiple cases, but what I'm trying to manage is a proximal tubal block. Distal tubal blocks are very easy to manage. You can just go laparoscopically, find out the distal block, put in your Maryland, and can just dilate the distal block area, and the distal block will be cleared. But proximal tubal blocking require cannulation. So that is what we'll be thinking about. The ones which respond well are muscular spasm or stromal edema, or some debris which are collected, or because of mucosal agglutination. These also respond well when you're doing a cannulation. Along with that, if you have a pathology such as corneal polyp or chronic salpingitis, endometriosis, is salpingitis erythemata nodosa, or intrauterine synechiae, these all respond well when I'm doing a pathology related to tubal block, which is a proximal tubal block. The ones which do not respond well to cannulation are luminal fibrosis, if it's a failed tubal reanastomosis, if there's congenital atresia, or if there's tuberculosis or leiomyomata. So you have to always try to rule out infective pathology and give a doxycycline or whatever antibiotic that you can do, and rule out pregnancy also. Hold your cervix and the way which we discussed regarding doing a basic hysteroscopy that you'll do. And then we use a cannulation set. The one that I use is the Cook, the Novi cannulation set. So this is the cannulation set that we use. And this is how when I open, these are the entire thing that I require on my trolley when I'm doing a cannulation for the hysteroscopic cannulation. So as you see, this is the entire cannula with the set thing. And this is what the guide wire thing when it's there inside. If you see the blue thing, I'm going back and forth. If you see the small blue thing, that's my channel thing, which will go in the operative sheet area. And from that, I'll be passing the small rigid part. So that will be going inside and will be dilating my cavity. I guess this is very clear. You'll be seeing in this also very well. So I always prefer doing a concurrent laparoscopy in such situations so that I can always see the dye coming in. I do a concurrent chromoperturbation. So once I'm done with my cannulation, I do a methylene blue test and I know that my cannulation has been successful. So this is always helpful doing a concurrent laparoscopy. So hysteroscopic cannulation are successful if you identify your patient properly, and proximal tubal block, though it's challenging, I think it's one of the easiest thing which you can tackle if you know how to do a hysteroscopic cannulation properly. The other things that you might come across are removing of foreign bodies while doing a hysteroscopy. You can come across different things. One is fetal bone parts, which can be because of abortion, the chances of you not removing the bone, or some doctor might have just cleaned it up and left a piece of bone behind, and this can lead to menorrhagia or vaginal discharge or pelvic pain or even infertility. If you do an X-ray, or you can find out an ultrasound, you might find a dense area. So this is how we identify that there's a foreign body which is there. Go in with a hysteroscope, find out do a proper distension, you'll find out some areas which are there. And with an alligator forceps, you just bring it out. If it's difficult, you can use a loop current and dissect the area, and then you can remove the bone part out. So if you see in this, there was a small chip of bone which was there at the corneal end, which was removed. And in the fourth picture, if you see, there's that nice small piece of bone which is there, which was removed hysteroscopically. The other thing is you might have lost foreign bodies which can be embedded in the myometrium, or it can dislodge and move up. words and can enter in the fundal area. That can be there, or the tail might be lost and therefore you might be searching for it. So you can always do an ultrasound and find out whether the IUCD is still there inside, and rule out pregnancy whenever you're doing such cases. Go inside with your um, grasper and just pull out the hysteroscopy by the hysteroscopy method. So in this, I've used a grasper, gone inside, just held the thread and pulled it out with that. This is how a normal the IUD would look in the uterine cavity, progesterone containing uterine, the IUD. In the third picture, you see the dislodged IUD, which is there inside, which is moved a little up, and the threads have also moved up. So you can just put in a tug on the thread and can pull it outside. Or the other thing is, if it's embedded, you might require a hook, IUCD hook, which is available, or you can just put a small lick with an electrocurrent surgery, which you can do around the myometrium and can pull out the IUCD outside. The most challenging thing that you might be performing while doing a hysteroscopy is tackling a uterine myoma, which is there, which requires a hysteroscopic myomectomy, which is done in cases of submucosal fibroid or intramural leiomyomas. You have to find out which category of category of the fibroid that you're tackling. Like I said, it is intramural, which is less commonly done, but majorly done in cases of submucosal fibroids. The advantages of this is if you're planning to do it, it's a very easy procedure. There's no cut which is involved, so therefore you can finish it faster. And the post-surgery morbidity is very less for the patient, and there's hardly any scarring on the uterus. Indications, it can be because of abnormal uterine bleeding or recurrent pregnancy losses or infertility. The patient might also, once you operate, there might be a few complaints of some parts of fibroids which can be coming out. How and why? I'll be telling you. Or the patient might have complaint of leukorrhea, or there might be evidence that you still have fibroid which is left inside because it might have intracavitary extension. It is not preferred in patients who have pelvic infection, or obviously if there's any pregnancy which is inside, or in cases of bleeding diathesis, because hysteroscopy, you can't control the bleeding directly, therefore it might be challenging at times. Removal of fibroids which are difficult, which are sitting inside the endometrium and the myometrium, will take a lot of time and that won't be complete. So that is also a contraindication if you have to do it in one setting. And obviously you can't do subserosal fibroid via this way. So basically your type 0, type 1 and type 2 fibroids are the ones which can be decided to be proceed ahead with hysteroscopic myomectomy. Whenever you're doing a large size fibroid, you have to explain the patient that you will require 2 or 3 settings also at times, because you don't want to go through and through from the uterus and remove the fibroid. So you have to do it hysteroscopically. But at one point, you can remove only 2 centimeter or 3 centimeter, because if you have a 5 centimeter uterine fibroid, subserosal fibroid, your opening is only for 1 centimeter maximum when you're doing a resectoscope. You can't remove a 5 centimeter fibroid from a 1 centimeter cervix. 2, if I have to remove the entire fibroid chip by chip, it will require a lot of time, which means that the patient will take in a lot of fluid inside. Therefore, my again major worry is fluid imbalance, which can happen. So that is why always do it in 2 or 3 settings, which will be effective for the patient, rather than doing it at one go, which will be incomplete, or you might damage the health of the patient. So evaluation of the uterus, again, you can do it by either saline infrasonography or vaginal sonography or MRI, so that you find out the position of the fibroid, the extent of the fibroid, and how you need to tackle it. You can think about giving a GnRH antagonist, agonist or antagonist, which will reduce the size of the fibroid. But what happens is, yes, it will reduce the size of the fibroid, but sometimes it makes it difficult to find the plane of the fibroid. So it's up to a personal call whether you want to prefer using GnRH antagonist or agonist or not. Using a misoprostol vaginally, also it's up to you. I usually don't use a misoprostol. I usually dilate it with my Hegas dilator, but if you want to prefer using a misoprostol, you can still do that. Vasopressin has to be injected so as to reduce the evidence of any bleeding which can happen. You have to be careful while injecting vasopressin so that there is no hypertension, bradycardia, or intraoperative complication that can happen. dilute it in 100 ml saline, and then you can give it at different positions wherever you feel that the bleeding will be reduced by giving it these positions. Resection can be done using a wire loop, which can be either a monopolar device or a bipolar device. If you're using a monopolar device, like I told you, you have to use a non-ionic, non-electrolyte solution, which is glycine. If you're using bipolar, you can continue using your normal saline or the rainbow lactate, whatever you are using during your basic hysteroscopy also. Newer techniques are available which can be used by using vaporizing electrodes or hysteroscopic modulators. You have to be careful, like I told you about the distending fluid, so that there's no overload which happens in. This is how one of the hysteroscopic myomectomies that I had done in. So you see the fibroid in the left side picture. We use the loop to remove the fibroid, and eventually this is the fibroid that we removed from the hysteroscopic myomectomy. That was the volume. This was around 3 centimeter myoma which we could do. We could do it easily because the fibroid was just hanging at one position. So I didn't have to push in much, and we can just remove it slice by slice. If it's embedded inside, or if it's a type 2 kind of a fibroid, then it's very difficult to remove the fibroid also. So these are the techniques which I've already told you. After the surgery is done, you can always think of adding a prostaglandin, which can cause contraction and can reduce the bleeding also. Or you might do a bimanual massage, and that also will reduce the contraction, the bleeding which can happen. Two-step procedure, if you think that the fibroid is too large and it can't be removed, and you do it again in a second setting, which is beneficial for the patient. You can always do a concomitant polypectomy or ablation along with these things if you're thinking about it. Complications, as in any other hysteroscopic procedure, you might land up with perforation or excessive fluid absorption. What you need to remember that fluid management system is very important. You can use different kinds of things. Either you use gravity to distend the cavity. Gravity is very effective if you just want to do one small polyp or just see the basic diagnostic hysteroscopy. If you need to do a myomectomy, you require a very good distension because you need to see properly. For that, you might either use a pump or you might use a dynamic central pump, whichever works better for you. If you have an inflow uterine cavity, always keep an outflow pump because you can check in the fluid which has gone inside and can manage regarding how much is the input and how much is the output so that you know how much has been the loss during the entire procedure. These are the different kinds of fluid regulation system that you get in. Either whichever thing works well for you, the arthro pump is something, or the histomat, what is available, are the common ones that we use in our daily practice. So this is how it works, basically the small diagram which I used to explain the biomed guys. So basically there's a channel which will take on the pressure and you can regulate the amount of flow which is going at a particular pressure that will maintain and make sure that you're not having any air bubbles in the pipe which is connecting to the hysteroscope. You need to understand basic system of physics when you're doing this so that the patient safety is maintained, so that you maintain the pressure along with your mean arterial pressure, and that is what will give you a proper distension. If you don't have a proper fluid management system, then you won't be able to see your cavity properly. There might be a lot of bubbles. That is why I told you that remove the bubbles. And inadequate distension can lead to visual impairment, and then you can't operate anything, but your fluid will keep on going inside, and that will lead to fluid overload. And you can also land up with a poor performance during the surgery. It can lead to perforation also or fluid extravasation. So you have to know that intravasation is something which happens in the cavity, in the myometrium and the serosa of the uterus. And the fluid deficit has to be happening wherever the fluid enters in the pelvic cavity, which will be absorbed from there. So try to always start with a low intrauterine pressure between 40 to 70 mm. So this is something which is low, but then you can just see all the things easily. And before jumping into your procedure, you always start with a low input which can happen in, so that you don't land up with fluid overload when you actually need to start with an operative procedure. This is what I was telling you, the mean arterial pressure. This is something which you can calculate, and this will give you a basic idea at what pressure you should maintain your fluid in the cavity. Fluid guidelines, always remember that do an electrolyte level before doing any major surgery. Deficit should be around less than 1000 whenever you're using a glycine solution. Normal saline solution, deficit around 200, 2,500 is something which is accepted. But then always think about adding in a Lasix, which can reduce the risk of pulmonary edema in normal saline. Like we discussed, hyponatremia is something which also is very common, which is seen in glycine, and in normal saline, you might land up with pulmonary edema. So get your electrolytes level checked and always add a Lasix whenever you're thinking that there are chances of getting fluid overload, which can happen in high intrahand pressure or low intrahand pressure. That depends upon what you're tackling and which situation. This has to be decided judiciously, because if you have to maintain pressure during intrauterine adhesions, if you have a low intrauterine pressure, then it's optimal, can assist in better orientation, but lower risk of perforation. When you have a high uterine pressure in intrauterine adhesion, there's disorientation because you won't either ostia properly, and probably you can't identify the proper adhesions also, and that will be difficult. Though you can operate faster and you can cut faster, the risk of perforation also increases in high uterine pressure. Myomectomy also, there is higher risk of getting fluid overload. So the dissection is better and you get a proper plane. So you're faster at dissecting whenever you have a high intrauterine pressure. Lower uterine pressure is better when you need to manage a very small fibroid, because you can finish it faster and there are less chances of perforation which are there. When you're doing a septum or a T-shaped uterus, when you have a high uterine pressure, it's a symmetrical dissection and easier maneuvers can be done. Low uterine pressure can be difficult because it won't distend the cavity properly, so you won't be able to see the septum properly. So it might take a little longer time overall when you're managing such cases. So depending upon whatever you're comfortable with, either low or high uterine pressure, I usually prefer a slightly higher uterine pressure because the procedures happen faster if you know what you need to be done. Keep everything ready and then just start doing the procedure so you can finish it faster within, like I told you, 5 to 10 minutes, maximum 20 minutes, you should finish your hysteroscopy procedures doing it. So how can you be better? You have to do a proper pre-operative evaluation of such patients so that you can provide better outcomes. Your skill will happen whenever you attend better, like keep on practicing more and you keep an idea about what are the complications that you might come across. So the perforation which can happen, or the fluid management, whatever you need to do, you should be ready for that. And your clinical outcomes and minimal complication will be happening once you select your patients better and you know your instruments better. So with training and practice, you can reach proper perfection. Thank you.
Thank you so much, sir, for taking out your precious time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice also.
Thank
As
you,
I
sir.
can see, sir, we have received some question from the participant. With all your permission, shall we take this?
Sure.
Yeah, the first question is from Dr. Singhdeshwar Singh, and he's asking what are the current guidelines regarding the frequency and indications for repeat heteroscopy?
Myomectomy. Otherwise, your hysteroscopy has to be better than a specific guideline wherever you have to repeat a hysteroscopy in cases of infertility, depending upon whatever findings are there. Majorly, if you're thinking about infertility and hysteroscopy, always think about sending the endometrial lining for histopath and tuberculosis testing. If you're thinking about polyps and everything, obviously your pathology itself can be reflected by the sonography. So therefore, you know whether the procedure was done completely or not. If you're thinking about myomectomy, then you can do it in 2 to 3 settings. At least keep a gap of 4 to 6 weeks, at least for the next period, so that things start evolving. And if there's any bleeding or whatever has happened, you start correcting that part, and then you move on to the second and the third step whenever you're thinking about doing a myomectomy.
Thank you so much, sir, for sharing your insight on this question. And moving forward, I can see another question from Dr. Anuvesha. And she's asking, how do you manage fluid distension during hysteroscopy, and what are the potential complications associated with it?
Okay. So this is a nice question. This I actually wanted to put in a slide which I forgot. So whenever I'm using a fluid media, so basics, whenever you're doing a basic hysteroscopy, you require normal saline. I usually use a monopolar energy source, so I have to use glycine. So normal saline, I'm allowed around 1.5, 2 liters. I usually limit myself to that. Glycine, it's 1 liter. I don't want usually my entire loss to be more than 1 to 1.5 liters. That is the cutoff that I maintain. So how do you plan for it? First, prepare your entire hysteroscopy thing, have your inflow channel and your outflow channel. Outflow is connected to a suction machine. Without the suction, it will just keep on collecting my outflow from the outflow channel, the water loss which is happening. Again, for my patient, I usually put in a plastic drape underneath, which is reaching out to a bin. So that will also collect whatever is seeping outside from the cavity in the bin. That's happening. So now, whenever I'm putting in a bottle of 1 liter for a normal saline or a 3 liter for a glycine, I know my input things, whatever are going in. So if you use a 1 liter saline, you don't usually finish up with that extra part. So whatever is gone in, supposedly I've used 700. So 300 is left in my bottle, 700 has gone inside. Now I have used 2 liters. For example, I'm just giving you small maths calculation, which my junior doctors, they know it very well. So imagine I have used two normal salines to see the cavity and done everything. So that was around 2 liters of normal saline, which the actual bottle is. When we checked in, around 100 was left in one bottle, around 200 was left in one bottle. So 100 and 200, that's 300 minus. So out of 2 liters, 300 has not gone in. So 1.7 has gone inside. I hope everyone is getting this part. Now, my drape will give some liquid which is collecting down in the bucket. So that I aspirate and check. Plus, my outflow channel is also checking for any fluid which is there. When I check the outflow channel and whatever is left inside in the bin, when I aspirate and check on that, that comes to around, say, around 1000 or 1500. So maybe 1000. So 1000 plus 300, that's 1300. So 1300 is the total which I've collected from outside. So what has gone inside is 700. So I know whatever has gone inside is just 700. My limit, what I've kept for myself for normal saline is 1.5. So now you know this is how I calculate my fluid. Maybe it's glycine or whichever normal saline. This is how you calculate. Always check how much is left behind in the primary container, how much is collected in the drape thing in the bin, and how much is collected in your suction machine ka bottle. Now, what I always do whenever I'm thinking that this patient will require resectoscopy, I do a pre-op electrolyte level. I know my sodium and potassium. If I feel that yes, this is still reaching a little higher, I'll do a post-op electrolyte level just to be medico-legally safe. I always ask the anesthetist also to give a Lasix 10 or 20 depending upon how much I've crossed depending upon my expected limit. So that is how you manage it out. So when you have the calculations properly, when you have done a pre-op properly, and when you know what you need to do post-op, and ask again after the surgery is done, ask the doctor whosoever is in the ward, or if you're there alone, monitor for the vitals, monitor for the SpO2, and look for the lungs again every time whenever doing a resectoscopy, so that you don't land up with the pulmonary edema. So these are basic things what you need to do whenever you need to manage fluid overload in cases of resectoscopy and hysteroscopy.
Thank you so much, sir, for explaining this question really well. I hope that the participant has got this answer. So, moving forward, I can see Dr. Manisha is asking, what are the key element of documentation during and after the hysteroscopy procedure?
So key element is first you have to your OT notes have to be better. You mention whatever you have done in and whichever way, whether you have used electric surgery or whether you have done it with just cold knife or cold scissors, because that will be also helpful in the future planning. And if you have done resection, you have to write down that resection is done and has to be given certain estrogen if you require or putting an IUD, because if the patient is majorly for fertility, my major part is always thinking about the fertility aspect of the patient. The patient knows how much she has to wait. Plus, your documentation has to include all the steps of surgery, including cold or any electrosurgery, so that the fertility doctor or the obstetrician should know that how much he or she has to wait for letting the patient to try to conceive, and even during the pregnancy, how much care she has to take.
Thank you so much, sir, for answering all the questions, sir. I hope, sir, you have able to clear all the dots related to this topic. Sir, as I can see, there is no more questions from the participant. I hope you have done justice to this topic. And, sir, and would like to see you as there is no more questions, sir. With all your permission, shall we conclude this session?
Sure, definitely. Thank you for
Okay.
that. Thank you,
Welcome, sir,
everyone.
and take care of yourself, sir, and hope to see you again in